So I don't know that this lady needs much of an introduction, but I'd like to welcome Loretta Ford up to the stage. We'll be asking her some provocative questions. So we're going to do this interview style. We have quite a few questions that we wanted to ask Loretta. How did you get the idea to initiate the NP role, and what was your vision for the future when you first started?
Well, I entered academics after many years of practice. And
closer to you.
most recently, not most recently, at the time, in 1961, I guess we started, I was convinced that the public health nurse, who was the health professional in the rural areas, the mountainous areas of Colorado, and as well as some of the city areas that we served. And we had really a generalized service because we didn't have all the other professionals. We didn't have a sanitarian. We didn't have epidemiologists. We didn't have huge numbers of physicians interested in public health. So that the public health nurse was actually the population nurse. We did everything. We did the schools. We did home visits on newborns. We inspected nursing homes. So when I say generalized service in public health nursing, I can tell you that our resources were the state resources. For example, one time in the tuberculosis new case we picked up, we could not trace the source. So the only thing I could think of was that this family had a huge German Shepherd. So I thought, gee, I wonder if dogs get tuberculosis, and maybe that's the source. So I called the state vet, and he said, oh, yes, it's a possibility. So I went to, and I said, well, how do you tell me? He said, oh, you do a PPD, just like you do the kids. So I went to the house, and here's this German Shepherd, who's almost taller than I am, and he seemed very friendly. So I said, well, so I said to them, maybe we'll roll him over on the, under his arm, his leg, his front leg, do the PPD. Well, that didn't suit him. So I said, well, I made friends with the dog, so he stands up and he puts his two front paws on my shoulders. So I'm looking up at this German Shepherd, and friendly-like, and pretty soon I took the little thing and stuck him. And he went, and he looked at me and said, licked my face and left. Unfortunately, he was not the source. But these are the kinds of things you learn from being the only health professional. So, of course, we did testing of the water and the wells, and everything followed up on the VD cases. And so I knew that there were many times that I wished I could be more definitive, because if I called any of the doctors, I was very careful to use the language of what I called nurse-ese. And so at that time, I really didn't have to, because most of the guys were pretty friendly and stuff, but I was very, very careful to be sure I didn't diagnose anything that would be. So when I went into academe at a very propitious time, there was an opportunity, both from the social and political environment, which was chaotic in Vietnam and Lyndon Johnson's time, and also the professional uprisings with lots of criticism of medicine, physicians going into specialties instead of general practice. And in nursing, the big deal was to advance practice. And in advanced practice, we were, as faculty then, challenged to identify the content of your specialty. So at that time, the nursing process was the big thing. And the collaboration with physicians, autonomy was a big effort. So the profession was saying all these things, and I had them printed. These are what we think we should have in advanced practice. So I thought the public health nurse was the perfect one in the clinical aspects of us to do some interesting experimentation. Now, if you're a faculty member back then, you sat around the table and conceptualized what content we were going to put in the curriculum. And we would meet and talk forever, and 2 weeks later, we couldn't remember what we said. So I thought that it would be better to experiment with it, and I was looking at the family nurse practitioner as the clinical part. And child clinics were the perfect place to begin to do some clinical evaluation in accordance with the nursing process. What's the first step? Assess, right? For those of you who can't remember. But I was working on that concept with other faculty in the Western region, and we had a public health nurse group going, and anyway. And then Henry Silver, who was a pediatrician, a deputy of the chief pediatrician in the medical center, contacted me because I had been working with his chief on a university committee, and he suggested that Henry Silver talk with me about something in pediatrics, because they were particularly interested in well children. And so Henry and I got together and developed a model. Now, you will see that the nurse practitioner came into being because there was a physician shortage. Well, I can tell you, there was nothing further from my mind than make up with deficiencies in medicine. And neither in Henry's either. Henry was interested in the care of children, and well children particularly, because they're both health-oriented and the maintenance of that, plus education of the mothers, fathers, and families. So it was a natural coming out of family health that we should do that. But it's interesting how many times you read in the literature that the nurse practitioner was substituting for physicians. And it's hard to dispel things that are once in print. As a matter of fact, what's in print is kind of interesting. I was out at a conference like this one day, but it was in the coffee area, and I sat at this table with this young woman, and I said, "Hi, I'm Loretta Ford." She thought of me, she said, "Are you the Loretta Ford?" I said, "I don't think I'm the, but I am Loretta Ford." And she said, "My God, I thought you were dead. I read about you in my book." So she said, I was very much alive at the time. So the poor child was very confused. So the kinds of things that you read sometimes about history are not necessarily true, and I'm hoping to outlast some of them, but it also created a lot of other problems because nursing faculty at the time were not collaborative necessarily with physicians in terms of teaching and learning. And so I had a lot of what you would call now bullying. And if you've never been bullied by academic faculty, don't try it. Believe me, it's a tough go. So, and there's only one change to change, and one really satisfactory way, or a very, very sure way to get people to change their behavior, and that's just outlive them. So, you don't think that's funny? That's true. Nobody's left but me to tell the stories. And so I suffered through lots of things in the early days, but the clinical role that we were demonstrating was really, unfortunately, not picked up by the public health nursing group, which incidentally was a very small group in the country. It also was fairly new to baccalaureate education. And there weren't many faculty who were actually available to develop this because the league, at that time the National League, had requirement that public health nursing be a part of the undergraduate program. So we really didn't have a great deal of strength or numbers in terms of students or in practitioners in the country. So the idea was picked up and taken to children. And of course, our greatest antagonists were the pediatric nurse practitioners, were the pediatric faculty who felt we were encroaching on their property, intellectual property. Anyway, so that was, and it was true, we were not quote-unquote pediatric nurses because of the nursing students, because at that time it was oriented mostly to hospital nursing and care of the sick child. So they did have growth and development and a few other things. So that's how I got into it. I thought I was doing exactly what the profession wanted. I used the nursing process. We called assessment, though I had to teach Henry the nursing language, because he would say physical assessment. I would say, oh no, assessment, just assessment, that's the first step. So depending on which group we were talking to, we used 2 different languages. To the medical board, we used medical language. To the nursing board, we used nursing language, and vice versa. So, we learned a lot from making more mistakes than I want to tell you about.
Can you talk a little bit about what you think we should focus on in the NP role today?
Well, I think the NP role today has a great opportunity to alter the culture in a variety of ways. First of all, to move the culture from a treatment orientation to the public health orientation for the preservation, promotion, prevention, and MEP you can think about in terms of practice, because I think the opportunities are there for culture. Do you know we spend more money on both outfits to exercise in than we do on taking the exercise? That's true. We're buying lots of outfits, but we don't use them. We walk around in them. So that I think we have a great opportunity to do that. I think another thing that's going to impact us is the biomedical and the genetics, so that practice is going to change appreciably in terms of these new technologies that are coming in. Some of you are wearing them right now. But I believe that when newborns leave maybe their homes or whatever they're going to be born in the future, there's going to be a chip in the back of their necks, like your dog. And it's going to have your health history, your genetic code, and a few other things. And you're going to be the one, as the patient, to receive the information first. And so the involvement and engagement of the patient, I think, is going to be a huge change. Topol calls it the democratization of the patient care. And if you want to talk about partnership with patients, for example, we talk a lot about it, but to really engage them and have them take charge and make decisions for their own health, and try to tell them that the one who knows most about you and your body and your thoughts and everything else is you. So you're the one who's going to have to make the choice. We can help you look at the choices, we can tell you the consequences, but in the long run, that level of accountability is transferred from the provider to the patient. And once they begin to believe that they're in charge, I think we'll see many changes
As the role developed and so many changes have occurred over the years, is there anything that you wish we could do over again? In other words, regrets and/or challenges?
I thought of firing squads first. But actually, I think one of probably the biggest error I made was not spending more time on organizational work. I was pretty busy staying alive and traveling and, advancing the role in many places. Because the organizations had yet to be convinced very much like the faculties, that this was a role. And actually, the ANP and all these specialty organizations have grown up because the traditional organizations didn't recognize you. They wouldn't provide for the council, they wouldn't provide for the things that when we were a small group. And in a way, I wish I had, not because of the organizations I grew up here, because I think we could not have done it without it. But it's still, because I believe you should belong to at least 4. And those 4 are the parent organization of the ANA, the ANP, like with me for the public health, whatever your specialty is, with other professional groups, and the community groups that are bringing about change. So I wish I spent more time. I wish I had more time to spend that way. Secondly, I wish I had been more vocal in the development of legislation. Because I've always thought that developing legislation, one task at a time, was not the best way to go about it, because you spend all your time and money and energy and frustrations on one item. And what you want really is, as some professionals have, is blanket across the state, a federal thing. Now, a good way to do that is to go for the money, right? Always follow the money. It will get you there, believe me. And so I wish I had been more active in that political, legal thing on a national level and go for the gold. And take organizations like the VA, the military, maybe Planned Parenthood, other organizations, that the March of Dimes, and all of those, we might have been able to, maybe not. I mean, what we did, I think, is a pretty quote-unquote normal way. But, you know, I wonder if we had, we didn't have so many gender issues politically, that we would have had a better chance of doing it autonomously. I don't know. While I'm here, I'll tell you, I've got one thing on my bucket list left. I want to live to celebrate the 100th anniversary of the women who got to vote in 1920. So you better be a part of it, because I'll be watching you from either down or up. Probably down.
Definitely up.
I'll be kicking you in the butt.
Definitely up. You're our angel. Can you talk about how your role as a nurse practitioner has impacted you and others?
Well, it's cracked my face at these meetings getting pictures taken.
I think that's a little bit of a hint, not to bombard her in the next day with pictures.
No, I appreciate your enthusiasm, your spirit, And I like it. I mean, I'm glad to do it, and I'm constantly amazed at the delight that people have in their role as nurses. They've done a lot for nursing. I think the nurse practitioners have advanced nursing as a profession, and I think it's elevated the standards of education. I think it's made the public press very aware of you, and you're not the only ones that are satisfied with your role. Those you're serving have. And actually, some of the challenges we had earlier in medicine are making changes as well. And that's another thing. I think it's time we realized that a team is not two persons. That we need to add many more people to our teams that we haven't used before. The biomedical piece, the engineers, some of the specialties in community action programs. And in that sense, think about it more broadly than we're thinking about state by state, just by this, because the Washington is not going to move until we make them. And you can't sit on the sidelines and try to be neutral, I don't think. And it's very obvious today that we have to be more and more supportive of the political efforts of our organizations. And hopefully the organizations will get themselves together too in unity when you go after something so that you can all enjoy it. Where do we start on this? What question was that?
About the impact of you that it's had on you and others. Maybe talk about your students.
Well, I think the impact that I've enjoyed the most, and I noticed it early in my first students, is that the people themselves have thought about themselves with more confidence, more self-esteem, and more enthusiastic about nursing. They enjoy it more. We have very few nurse practitioners who don't really enjoy being nurse practitioners. And I like that. I like the enthusiasm. What worries me a little bit is that sometimes you get your kick out of 66, and that means 66 diagnoses rather than 66 patients who have taken on the responsibility for their own health and look at it more broadly. I think coming from public health, some of the things that you are hearing about today and learning about and thinking about and teaching about are things like population health social determinants of health and all that. We did that years ago. We didn't have the language of it so much, but the district nurse was population health. It was our responsibility for the population in that area. And, in the riot, you don't remember them, you're too young, but in the riots in Detroit, the only ones years ago, I can't remember the year, but they were very early riots in Detroit, race riots in Detroit. The only ones that could cross their lines were the public health nurse, and they did it safely. because they had escorts that took them through the lines. And so this trust that we enjoyed every year from the Gallup polls started a long time ago. And we have a rich history in public trust, and I don't think we'll lose it if we always think about it in terms of public good. We're really serving the public. Now people are talking about the health professional as a servant to the people. Well, I can't see that exactly happening in some profession. But I'm hoping that. Which reminds me, we haven't talked about language much, but I think it behooves us to watch our language and talk about primary health care. Primary medical care is a different breed of cat, and the system is very strong in identifying who gets what in the distribution of funds. And so if you want to really change the culture, you have to change your language as well. While we're on language, let's not talk about independent. Look, you're not independent of anything. As a person, as a professional, whatever. We depend on the staff here to put us together. We depend on, if you work in an office, you depend on your co-workers. The physician depends on his staff or on his technologist or a social worker or whatever. So no one is independent. It's interdependence or autonomy. Now, statutory autonomy is different from the independent practice, because statutory autonomy tells you you have something to offer and it's state accredited. And how you use it then is your own, within the limits of that statutory authority, but not task by task. If you go on for task by task, you're going to be forever knocking on the doors of the state legislatures. And it's a waste of time for them. It's a waste of money. And, you go for something, some treatment, something, and it goes out of date. The things I learned, half the things you learn, someone said, I think it was Osler, half the things you learn will be outdated before you get out the door. The trouble is, which half? And so you have to think about that. And the learning of why, or the assessment that we go through, I think is vital. Not because of the technique, but because of the process. And it took us a while in education to realize that we should be teaching process, not content. What are you getting your content? you pip up your cell phone and ask Alexa, she'll tell you. It's true. It's true. Yeah. So I think things are changing rapidly. I'd like to see us be part of that change, not on the recipient side, but on introducing change. And when we're teaching students a process of anything, start telling or asking them, how could you do this better? Better for you, better for the patient. Look at the economy of it, and look at it long range. Everything is short range today. You don't think about what's going to happen. So I'd like to create students who, or give them a chance. I call it cracking the eggshell. Cracking the eggshell. What's in them to do? Why teach them all this stuff that they're never going to use? They could look it up. By the time they look it up, it will change. So that kind of curiosity and synthesis of information and that sort of thing, I think the critical thinking part of it has been less emphasized. That's the kindest thing I can say. I learned by the numbers. It was like painting a picture. You put red here, and you do it in order. Number one is number one, number two is number two. Of course, I never knew what we were doing at 3 a.m., so it didn't matter.
What do you see in the future in healthcare for nurse practitioners?
Well, some of it I've already alluded to, but I do think there will be changes in healthcare. And I think we have to have a strong political bloc to be a part of some of the changes that are occurring and will occur. And we have to join groups that are not normally coordinated with or cooperated with. But I think if we keep in mind that we have a role to play, and a big role to play, in terms of the culture of health, we will do well, because I think that the problems out there in terms of health care, whether it's financing or access or availability or distribution, are going to have to be dealt with, and I think they will. I won't live to see it, but I'll be watching from wherever I am, and kicking, right? So I think the future, despite the current upheavals we're having right now politically, I think you have to be optimistic, because remember that crisis is opportunity. In Chinese, that's the only thing I know about the Chinese language, but the symbol for crisis is also the same as opportunity. So we should take advantage of this crisis and not sit back. So, there's a crisis. Nobody knows what's going on anyway. And so you can formulate a plan and move with that in a way that would be for the public good. And I've been known to say that there are three things that move the macro world: power, control, and money. And people say, no, love makes the world go round. It may make your immediate world go around, but believe me, out there, it's power, control, and money. And so you've got to be a part of that big area of moving things. And I don't think it's going to be one nation. I think it looks like it's going to be pretty global. So don't think little, think big, think solidly, and move the forces together. Okay. Got another one.
So, Lee, you're famous for your alliterations, right? Do you have any now?
Well, I always think of, this is an alliteration, but it's how I got to it. I always think of the late Warren, Elmer Warren? No, Elmer. He was the state Supreme Court, a famous one. Anyway, he said that everything I ever did in life that was worthwhile, I caught hell for. And I feel that way about my passion for nursing. And the alliteration is summed up in this way. I've been kicked and kissed. I've been reviled and revered. I've been crucified and credited. But I haven't been Botoxed and detoxed. I hope I didn't.
Oh, no, wonderful, wonderful. All right, so we'll take some questions from the audience.
Hi, Loretta Ford. I became a nurse practitioner because of you.
She became a nurse practitioner because of you.
Oh.
I grew up in eastern Washington State in a town of 1,000 people. And after I graduated from the University of Washington School of Nursing and became a public health nurse, I was introduced to a person who was one of the first graduates of your program who worked for the Seattle King County Public Health Department. And I had been so frustrated going out to see kids in Seattle, not being able to look into their ears and to determine whether or not they had an ear infection when the mother thought they did. I said, I've got to do this too. So I became a PNP. And I've been working in New Jersey. I know, I went all the way from Washington to New Jersey. And I've been working in...
Girls here.
Yeah, a lot of good, great New Jersey girls, we know them. So I've been working in health policy as a sideline to clinical practice and education and all the other things you do. You know, you do all those things in New Jersey, and was one of the co-authors of the bill that gave us titling and prescriptive authority. So I was so frustrated by having to go down the hall and ask if a physician who'd never even inserted a diaphragm or fitted for a prescription for one. I said, you know, we need to have this too. Anyway, what I wanted to just say was that I found in trying to mentor people to do policy work, which I think is vital, it's very difficult to do now, particularly because nurse practitioners can make so much money working in clinical practice. I mean, so much more than any of the rest of us did early on. We didn't work for money. It's very difficult to get people to do it on a daily basis because there's not a lot of money in policy work unless you're working for an organization where you can be paid a salary. So I would just like to say for everybody out there who's working with young people, try to get them engaged in the value of policy work. Don't you think? Do you have any idea about how we can do that?
Yeah. Well, part of it is bringing it home to them, I think. If they come from homes where their parents talk about politics and things, or they look at them, or and young people, you can be assigned, the debate has gone out the wall. I don't think kids today do much in debate as a learning strategy, do they?
No.
It's not used. Years ago, we used to use, 100 years ago when I was growing up, we had debates, we had to research a problem. And so I think some of it is the strategies that we use in teaching and learning, perhaps, or taking them to debates, or, sometimes when you go to a meeting, you're so dry, you're way off someplace else. You're not there. I saw a really interesting saying. I said, when you're there, be all there. And if you get the kids, when they're in a situation, to be all there, and you too, by the way, in meetings, you have a sense of focusing, of concentrating, of being interesting in terms of that. So I think young kids today, with what's happening in the schools, are a prime opportunity to engage them. You notice that the high school kids are gathering together and making some political waves. Use it as an opportunity for others. So I suppose it's opportunity teaching, learning.
And Lee's met my daughter Chloe, I call her my hippie daughter, and I have a garage full of political signs and all the protests she's been to and all her opinions. So get these young people to talk about politics and to talk about opinions and to speak up and to attend rallies and marches. I know, to be careful. Given the climate of NPs working so closely with physicians and aligned with the medical model, how can we encourage NPs to keep caring in our profession?
Well, first of all, I think before you go into any partnership and stuff, you need, and particularly today, you need to negotiate the terms of your arrangements, because the reimbursement system is such that particularly primary care physicians have a very difficult time making it financially, and we have to be aware of that. But I think what we had to offer is really more closely aligned with what the primary care physician wants. But in that way, if you're going to do what he or she is going to do, you're not doing nurse practitioning. And if they require you to see so many patients a day that don't allow you to practice the way you know you should be practicing, I think that's part of the problem, that the reimbursement is such that you've got to see so many patients. Now, there are some nurse practitioners who should have been doctors. They really, get their kicks out of diagnosis and all. And I appreciate the critical thinking that goes into something like that. But if that's all you're going to do, you'd be better off in a medical situation that demands you. You're not a substitute, right? I worked with a specialist, I think he was in gastroenterology or something like that. And as a demonstration project, and I took care of all the family things in that, in terms of also using my assessment skills. But his patients were much more well treated in terms of what their needs were. Because if you look at the clinical aspects of medicine, when they teach medical students assessment, a patient comes in, it's called, you know what it is? What is your chief complaint? What is your chief complaint? And it's the way we practice. But if the system demands that we have seizures, so you almost have to go that route because they won't pay for health care. That's why I think the changes to orient the culture is so important, because there are times and situations where you can't. Now, we didn't talk about telehealth or all the technical stuff that's going on today. You could be replaced by a robot if you're just going to do that. The robots may be more threatening than the MDs. You never know.
Do you believe the NP specialty roles have positively or negatively affected the profession?
Well, I think they're positively affected the profession, except that if it separates them out too much from the generics of the profession, I wouldn't, and that may be an individual thing, how they're, the specialists. Actually, there are some things in, let's say, diabetes is probably the most obvious one. I think those patients need nurse practitioners who are very knowledgeable in that particular field because it's so related to daily living. So there are some things that I think specialty in any field with the expansion of knowledge so much is bound to happen.
What made you decide to go into nursing as a younger woman?
Well, I didn't have any choices. First of all, I didn't have any money. And I wanted to be a teacher, but it took a circuitous route to get here. I found that I liked nursing, but I graduated too early from high school to go into nursing, so I was a nurse's aide for about 18 months. Doesn't pay to be too smart. And and I was there, and comfortable, and I'd read all the students' books, so except for the instructors who were all very strict about that 1, 2, 3, 4 procedures. but I did want to be a teacher. But at that time, you only had, well, you could go to the convent, you could go to nursing school. That was pretty cheap at that time, because the tuition wasn't great, and you were the slave laborers of the hospital, so they took it out on us in that way. I mean, we were the staff of the hospital when it came down to it. So.
As we teach and mentor new NPs, we must teach them the history of NPs. Is this a plant from the History Committee? What elevator speech about your role, about you, would you want new NPs to hear? So about you. What would your elevator speech be?
I'm not sure. I'm some kind of a nut. Well, I think that they shouldn't be afraid to take risks. There are consequences and there will be failures, but in a way, life is good, and maintaining some optimism about it, and getting your kicks out of seeing your patients become engaged, get well, or die well, whatever. I think there are so many blessings in nursing that when you go home in the evening, you feel so much better, because just think how lucky you are not to be in that bed or wherever. Of course, there's not many patients in bed. They're all vertical today. But not having the same problems, you wonder whether you would have the strength that they exhibit. And so, and some pride in what you were able to do to help them deal with it. And so it's hard to be very pessimistic about nursing, because you see so many responses, and sometimes they're little, but even those are so much better, and you're so much better off than your patients are, that I suppose it's a matter of attitude. You're going to be, dissatisfied with yourself and others. Well, maybe you're depressed. You could do. I mean, I can't diagnose all of you from here. You don't sound depressed.
All right, for our last question. You are an avid reader. What authors have inspired you, and whom do you follow? And don't talk about your romance novels here.
Oh, I'm an avid reader, yeah. Right, yeah. Well, I am an avid reader, and I read a lot about military and leadership in military things and strategies, things. I'm really a big believer in, which I discovered in developing this practice, a very strange, stressful situation, thinking you were doing exactly what the professor wanted. But we worked with a social scientist who was the evaluator of our program, and he was also a community activist. And he began talking about theories of change and things. And I think what helped me most in this was he came up with a couple of theoretical orientations that I really studied in depth. And then I chose one, I don't even remember the guy's name I chose, but in it, it was a framework of developing strategies, logistics, and tactics. And if you think about the problems in that way, change becomes a game. You know, you can try different strategies. For example, one thing that the pediatric nurse practitioner said, why are you, faculty, why are you teaching that? It was growth and development and assessment of newborns. We are doing that already. So that was a big bone of contention. So I thought to myself, there were several others, but I chose that one. You know, if I don't want to do the same thing you're doing. Strategy was to look for one little sliver of things we agreed on, and the strategy then was to test it out. And the logistics was to select the subjects in a way that it was gave them the advantage, and then the tactic was to test it out. So I said, well, if we're doing the same thing you are, I'm not going to do this anymore. I'll tell you what, you take 10 of your best students, and you can select any of my 64, whatever you want. I don't care which ones you take, and we will videotape them this one task of an in-depth assessment, physical assessment. And the logistic was that the data, I said, we'll have an independent judge. We will not be the judge. We'll have an independent panel judge them. We'll videotape them, compare them, and then the tactic was to nail them to the wall and crucify them. And you know, two things happened. One, it never said that again. I mean, it never was a criticism. And secondly, it went on and I got God credit for it. So think about it in that way. Now, it wasn't set up, it was a, you know, I was serious. I said, well, if this is something, I was fairly sure that I was going to win that one, but it helps to be pretty sure you're going to win. But with a theory of change, it took it outside of the feelings of it and all sorts of things. Well, what can we do to agree on, right? This is a compromise. I could go to Congress and teach them that about the things they agree on, and then begin to, you know, test it out. So once you got into that, things that were, that always helped me in terms of things that changed.
Well, that's all the questions we have. I want to thank you again, Dr. Ford, for coming here and imparting your extraordinary experiences and wisdom to us.
It was a lot of fun.
I love you, Doc.